Good evening, all. Let me share my screen. Screen is visible. Good evening again. And this topic was suggested by some of the students that I should talk on abnormal labor. Yeah, that's a very apt topic for a gynecologist. I would rather call myself an obstetrician when I'm dealing with a topic of abnormal labor. I think if there were to be no abnormal, there would not have been any obstetrician at all. So this is a kind of bread and butter for the obstetricians. And the normal labor, which we call as Eutocia, the terminology that we use for abnormal labor is Dystocia. So just for a revision purpose, normal labor is something where there is a singleton baby getting delivered by vertex presentation at or near term, the labor being most often spontaneous in origin, the duration of the whole process of labor not unduly getting prolonged, with minimal assistance, with a favorable maternal and fetal outcome. As an undergraduate student, we expect you to tell all these points when we ask you what is normal labor. And anything beyond this, if it is a multiple pregnancy, presentation by breech, or any other non-vertex presentation, delivery happening before 37 weeks or after 42 weeks, and the duration getting unduly prolonged, most often beyond 24 hours, or when you apply a pair of forceps or the vacuum for delivering, or compromising the outcome either of the mother or the baby. All these or any one of these things would make it abnormal labor. So again, the most important point that one should remember here is that dystocia or abnormalities usually occur in about 15 to 20% of the cases. 75 to 80% would not have any kind of issues. They go for an uneventful delivery. But what is the unfortunate aspect of this dystocia is it is not predictable. You cannot know which case is going to shoot a trouble and at what stage it is going to happen, what is going to happen. So just to give you an example, a lady can present with antepartum hemorrhage. She can present with postpartum hemorrhage. She can present with cervix not dilating properly. She can present with preterm labor. So all these things are labor related abnormalities. Dear students, I would not be discussing anything about the medical disorders that are complicating the pregnancy. Maybe I'm not going to talk about GDM. I'm not going to talk about the hypertensive disorders which are complicating the pregnancy or the labor process. I'm only concentrating on just the labor per se. So here we involve three aspects. One is the passage, second is passenger, third is the power. Power is of the myometrium or the uterus, and of course you can also add the placenta, right? The 4 P's. Important ones are the first 3 P's. You can get into some trouble because of placenta blocking the way, most often placenta previa, right? So in this session, we try to discuss some of the problems associated with power, passenger, and passage, right? Discussing about power, we are going to talk about the problems that the uterus or the cervix can pose to us. And about the passenger, most often it is the malpresentation and malposition that is going to be shooting the trouble during the process of delivery. Of course, passage is one thing which I think most of you are really worried. Even in your examination, when you are given the pelvis and you are asked to describe about the cephalopelvic disproportion or contracted pelvis, you will be really probably would be praying God that you should not get this kind of question. Don't bother about it. You can just watch the video in which I have in detail demonstrated how to do the CPD assessment and how to look for the contracted pelvis, right? So we start with the power problems. Power in the sense, what I mean here by power is the uterine activity. Causes for dystocia, passage, passenger and power, and we move on to the problems with the power. So about the power problems, we have the classification as the problems with normal polarity. The second one is with abnormal polarity. Dear students, you should understand what exactly is the meaning of polarity. The pacemakers in the uterus are situated at the cornual end, and the contractions begin at the cornual end, and then they move from the upper segment towards the lower segment, and by the time they reach the lower part of the uterus, the contractions are very, very mild. They don't really make the myometrial contraction a powerful one. So the contraction moving from up to the from the fundal region to the cervical region is called normal polarity. Sometimes these pacemakers are so vaguely or haphazardly located in the uterus that everywhere the contractions are initiated, or it is initiated in the lower part, it is initiated near the cervix, sometimes on the lateral wall. So these things will make an incoordinate uterine action. This is called abnormal polarity. So normal polarity, the uterus could be acting too much, which is called hypertonic, and uterus may not be acting properly. This is called hypotonic uterine contraction. The abnormal polarity, you start seeing a kind of abnormal constrictions, abnormal kind of myometrial contraction around the constricted parts of the baby. So the best example is the neck. If you look at the structure of the baby, you have the head and thorax, and you have a constricted portion as neck. So around the neck, the uterine musculature starts contracting and it will never relax. So this is called constriction ring. It is not with a normal polarity. Asymmetric uterine action is something wherein the right side and the left side paratubal area, which should have the pacemaker, will not symmetrically contract. One side may contract, the other side may not contract properly. Spastic lower segment, the uterus, the upper segment is always a contracting segment, and because of the contraction, the baby starts moving down towards the cervix. And if the cervix doesn't yield, if the cervix also starts becoming spastic and it is not responding to the push given by the upper segment, then the labor comes to a standstill. This kind of condition is called spastic lower segment. Generalized tonic contraction, whole of the uterus starts contracting with almost the same kind of intensity. The intensity need to be highest at the cornual end, lowest at the lower end. But here, the whole of the uterus will be contracting and relaxing irrespective of the area. Every part would be acting. And the last one is called colicky uterus, in which the whole of the uterus acts as a single structure which is contracting powerfully. In generalized tonic contraction, you have got multiple pacemakers. In colicky uterus, the whole uterus is tonically contracted and it will never relax in between also, right? And finally, sometimes with all these contractions of the upper segment and the lower segment also trying to yield, but the cervix totally fails to yield. This is called cervical dystocia. So a small description about these things. Hypotonic, it may start from the beginning of labor or it may set in during the course of labor. A lady who was getting good contractions suddenly stops getting contractions. Usually when the contractions are not there, neither the baby nor the mother are adversely affected, but the problem is labor comes to a standstill. Labor does not progress because there is no pushing effect by the uterine musculature, right? And diagnosis is usually done by palpating the uterus, comfortable mother, and halt of progress, right? So with these things, we know that this uterus is not acting properly. So how should we treat it? When the tone is not good, you should give something to increase the tone, right? So just reassure the patient and give her uterotonics. So how do you stimulate the uterine contractions? One is by artificial rupture of membranes you can do, or you can start using oxytocin. Only one thing that you should remember in these cases is that these patients may have an increased possibility of going for postpartum hemorrhage because the uterine tone is less during labor. The same thing may continue even in the third stage, and placenta may get retained, or postpartum hemorrhage can occur. So this also is known as uterine inertia, and there are two kinds, primary inertia and secondary inertia. So whenever there is primary inertia, uterus fails to act. Secondary inertia, usually the uterus, because of fatigue, because of maternal fatigue, or before rupture, and when you have not diagnosed the cause for halt of labor, it could be a malpresentation, it could be contracted pelvis, it could be a cephalopelvic disproportion, etc. You can have the problem. If it is secondary inertia due to these things, you have to do a cesarean section, right? The next one is incoordinate uterine action. Coordinated uterine action is with fundal dominance, and as it goes down, the waves go down, they should be of lesser intensity. Incoordinate is that there is lack of polarity. So this usually can happen either in the latent stage of labor or active stage of labor. Contractions are irregular, prolonged labor, the tone is highly elevated. Here you should appreciate, when the tone is more, the mother has to spend more energy for contractions, and the uteroplacental circulation is affected because of persistent and irregular contraction. So both the baby will suffer and also the mother also will suffer. So this is the problem with the incoordinate uterine action. Spastic lower segment. This is the next condition. Here the polarity of the uterus is reversed. That means instead of the fundus taking the dominant position, the lower segment of the uterus takes the dominant position, and the contraction starts spreading from lower segment to upper segment. So lower segment is the passage through which the baby has to come, so it should always relax. Here, instead of relaxing, the lower segment starts contracting. It is not rhythmic, and basal tone is always increased. In between, uterus fails to relax and patient is in continuous pain. Uterus is tender, and FHS variability also can be seen. You can also see the signs and symptoms of fetal distress like meconium stained liquor, and if you are doing a CTG, then variability. Of course, here though the first sentence I have written is assurance, let it not be a false assurance. We should always tell that there could be an adverse outcome with the baby unless it is managed quickly. The mother would have got dehydrated. We have to replace with fluid. Acidosis needs to be corrected, and bladder catheterization is one important thing here. And finally, the baby has to be delivered by cesarean section, because here the lower segment is not allowing for the passage at all. Cervical dystocia, as I told you, the cervix doesn't yield at all. Though everything is favorable, cervix fails to yield. So this can happen in malpresentation, spasmodic cervix, or sometimes you can't explain why this has happened. But secondarily, if you have done a cervical amputation, you have applied repeated cerclage of the cervix, or post delivery previously she has been repaired. She has had a cervical tear and it has been repaired, or there is conization procedure or any such thing, then the cervical dystocia can be an acquired one, right? Management, as the cervix doesn't dilate, if the cervix is very thin, you have a special procedure in obstetrics called cutting the cervix, which is called Uterine incision. Not very routinely practiced, but if it is a really indicated case, you can do it, or you can go for a cesarean section. Now coming to one more event wherein you have a kind of, it's not a obstructed labor or prolonged labor. It's a very quick labor. Both first and second stage together will happen in less than 3 hours. It could be because of hyperstimulation of the uterus. Here, the mother usually will have a good pelvis with a small or average sized baby. The position would be favorable, and it is also defined. This precipitate labor also is defined as dilatation of 5 centimeters per hour. That is, whole of the process of labor usually getting over in 2 hours. Usually occurs in multipare, and soft tissue resistance is less in these patients, and cocaine addicts, and in preterm labor this is more common. So why should we worry? Is it really dangerous to have a precipitate labor? Is it not advantageous that quickly she will deliver? No. This quick kind of delivery, while she is walking into the labor room, the baby can fall down. This is the quickness with which delivery can occur in precipitate labor. So this can cause abruption. It can cause bad tears of the cervix, perineum, vagina. Then it can cause PPH, both traumatic PPH and atonic PPH. Uterine inversion can occur, right? This is one more very serious complication of labor. Uterine rupture, amniotic fluid embolism, and of course, because of these kind of multiple trauma, they are also more prone for infection. Fetal complication, injuries can occur to the baby, low Apgar score, cord can just get torn and the cord can bleed and cause fetal anemia. Plexus injuries can occur, baby may die, or it can also result in aspirations, right? So how do you manage once you know that there is a quick progress of labor, or if there is a history of precipitate labor? You have to hospitalize the patient even before she gets into labor, and don't allow her to get into spontaneous labor. It is ideal that you do an induction. Don't give uterotonic agents because she herself is known to progress properly. Sometimes you may have to give tocolytics like magnesium sulfate, nifedipine, or terbutaline if available. And to avoid sudden release of the head from the perineum and causing some pressure effects on the head of the baby, you may have to consider giving a liberal episiotomy, and head has to be delivered with a very controlled manner, right? So this is about precipitate labor. You may get a short note question from some of the universities on precipitate labor. So you should write what is precipitate labor and what are the effects of precipitate labor and how we manage precipitate labor. So tonic contractions of the uterus, more than 5 contractions in 10 minutes, new pacemaker. This is one thing which you should remember. Other than the 2 pacemakers that are the cornual end, you have got development of new pacemakers. All of them start acting together. Though there is no much risk of rupture here, the problem is the risk of fetal distress, right? So how we manage these kind of things? Usually this also has to be delivered by cesarean section, but you can consider giving tocolysis to see that the contractions are slightly less. So I think just to summarize the power problems, usually it is with normal polarity or altered polarity. Normal polarity would be hypotonic and hypertonic contractions, whereas with abnormal polarity, it could be a spastic lower segment, it could be precipitate labor, incoordinate uterine action, tonic uterus, right? So these things are the ones which are usually encountered, and whenever the tone is high and fetal distress is a problem, cesarean is the answer. When the tone is low and you are not much worried, you have to increase the tone with the use of oxytocin. Now we go to the next problem that causes abnormal labor, the passenger problems. The passenger problem, maybe the baby has got some anomaly, maybe a hydrocephalus baby or an anencephaly presenting by breech presentation, a huge baby. Many a times anencephaly babies could be macrosomic, right? And babies with some abdominal tumors, etc., wherein you can expect, because of the passenger, the baby may not be able to negotiate the passage. Of course, big baby, which could be there nowadays with the massively obese women, and of course, the diabetes in pregnancy. Then malpresentations that can really trouble us are the bro presentation, mento-posterior face presentation, shoulder presentation, right? And of course, card presentation, and of course, some of the types of breech presentations can be really troubling us during the process of labor. So what do they cause? Labor cannot progress. Some can be rectified. Some can be picked up very early in labor. For example, if it is a breech presentation, you can pick it up very early in labor. If it is an anomalous baby, she can come to you with the report that it is a hydrocephalus baby. But you may miss of bro presentation when she is 2 centimeter, 3 centimeter dilated, and you will come to know about it little later. So some can be picked up early, some cannot be picked up. Why? Many a times you get still patients with these problems. See, they may get referred from some other primary health care center or secondary centers to tertiary care centers. So by the time they come, most of the problems would have crept in. Early diagnosis would have saved both the mother and the baby, but here it may be the baby or the mother would be in a moribund conditions. And as I said, bro presentation can be missed, and malposition, the only malposition that we come across in obstetrics is occipito-posterior position. So this occipito-posterior position with partial anterior rotation by 1/8 of a circle, and if it fails to further rotate, it can cause deep transverse arrest. So this is diagnosed only in the second stage. Till then we're thinking it's going to rotate. So this is one more problem. And in case of borderline CPD, when you are allowing for trial of labor, you are trying whether this lady can progress in labor properly. In such cases, it may fail and you may have to do, the lady can go for a non-progression, right? This becomes more common whenever you have an unbooked case, clinical assessment has not been done properly, or the earlier scanning reports are not available, or I would really put the most unfortunate event to be labor not monitored properly, right? Unless you mark a partograph and look for the a good progress of labor, you may miss the non-progression or abnormal progression of labor if you don't look at the partograph. So what is the unfortunate conclusion? It results in obstructed labor. Transverse lie will go for hand prolapse. Bro presentation will never get engaged and will come to a standstill. CPD fails to perfectly enter the pelvic cavity. Occipito-posterior position can become a persistent one, or it can go for deep transverse arrest. Mento-posterior face presentation, if left undiagnosed, goes for obstructed labor. It cannot go for a vaginal delivery. So the normal mechanism of labor, which involves engagement, descent, internal flexion, then continued descent and extension. One of the intrapelvic mechanism fails to occur in any of these conditions, and thus it concludes as obstructed labor, right? So face presentation, I have shown a few pictures here. Brow presentation with a deflexed head, breech presentation, shoulder presentation, and the last one is the shoulder presentation, in which because of the very good contraction, whatever part can come out will come out. In shoulder presentation, hand is close to the cervix, it just comes out. This is called hand prolapse, a very unfortunate event which occurs in shoulder presentation or transverse lie and results in obstructed labor, and if it gets neglected, it's going to cause rupture of the uterus. So obstructed labor is defined as, in spite of good uterine contraction, no progress of labor. This is due to usually mechanical obstruction. The presenting part fails to descend. 1 to 2% is the incidence of this. Upper segment is contracting. It has a normal polarity. Lower segment is stretching like a gunny bag. It is becoming thin, it is becoming relaxed, and it is trying to accommodate the baby, the parts of the baby which are being pushed by the upper segment towards them, right? So you have a thick and contracting upper segment, thin and relaxing lower segment. So a very clear demarcation between the upper segment and the lower segment, and this junction is known as retraction ring or Bandel's ring, and this ring becomes very obvious if the baby fails to descend further, and the whole of the baby many a times is now accommodated only in the lower segment, upper segment just sitting as a hard mass above the baby. So this junction is called Bandel's ring or retraction ring. Please remember, students, I mentioned one more ring called constriction ring. Constriction ring is around the constricted part of the baby, usually around the neck, and it is almost always transverse and it doesn't move up or down, right? Whereas Bandel's ring keeps moving up because the lower segment starts stretching, and the lower segment, when it is moving up, the Bandel's ring also starts moving. So if you just look at polarity of the uterus, the pacemakers are located and the uterus, and look at the first two pictures are showing you on left side. First two are showing how the segment is becoming thin and getting incorporated into the upper segment, and if you look at on the left side, two more pictures just below this showing the cervical dilatation and the passage becoming clear for the baby to come out. Same thing shown on the right side diagrams with the baby inside. The upper segment, which had a particular thickness, has become further thickened in the second picture, and the baby is moving down and down. And when the baby is moving down, you can see the dotted line, that is the junction between the upper segment and the lower segment. You can see how it has moved almost an inch up in the second picture. So this is the pathophysiology of occurrence of Bandel's ring. So what happens if there is a formation of Bandel's ring? One of the favorable events that can occur is uterus can stop acting, inertia. So this is one of the safest event which prevents rupture of the uterus. But in most of the unfortunate cases, it results in rupture, and this rupture occurs along the Bandel's ring most often. And the baby coming and occupying the lower segment and pressing on the bladder causes bladder pressure. Sometimes bladder wall can undergo ischemia, necrosis. It can bleed inside. Many a times you can also see hematuria. Fetal distress is almost a rule, and many a times baby also can die inside. Just look at the normal shape of the abdomen in the first picture, and you can see the retracted upper uterine segment, distended lower segment. You have the Bandel's ring in between. This is how it appears. Nowadays, you may not be able to see these things. We should take it as a fortunate event, because an early decision about obstructed labor, and most of the patients are coming for hospital delivery, institutional delivery. These kind of things are becoming less fortunate, right? So I just mentioned about the constriction ring. Then the effects of these things on constriction on baby and the mother gets dehydrated, exhausted, there is acidotic breathing, pain, anxiety, sepsis, there is increased incidence of operative delivery, very high chance of PPH, uterus rupture is a real threat here, death of the mother, death of the baby, injury to the genital tract, right? Of course, coming to the baby, asphyxiated baby can be born, baby can have acidosis and also hypoxic ischemic encephalopathy, intracranial hemorrhages, stillbirth, neonatal death, and infections are common. The remote complications of obstructed labor are vesico-vaginal fistula formation, chronic anemia in the mother, nerve injuries, both to the mother and also to the baby, sometimes because of operative or instrumental deliveries, and because of the trauma, because of so much of trauma and instrumentation around the vagina can go for adhesions and atresia. Part of the vagina can become cicatrized, and PPH can cause Sheehan syndrome, and of course there is an increased risk of uterine rupture even in subsequent pregnancies. These are the remote complications, right? So during obstructed labor, how do you diagnose that my patient can go for a rupture uterus, right? It is not right on our part to diagnose rupture. Always diagnose imminent rupture. It is about to get ruptured. So one of the earliest signs is fetal heart variation. If you are really counting or tracing the fetal heart, the variation in the fetal heart will tell us that the uterus might give way at any time. Tachycardia, hypotension, sweating, high colored, or the urine becoming hematuria, and sometimes you can also feel the round ligament. In fact, it is called Frommel's sign. You can feel the round ligament taut and stretched one, edematous vulva, hot vagina, most often membranes ruptured with meconium or blood-stained liquor. If you look at or feel the head and suture lines, you will see that there is overlapping of the skull bones causing so much of molding, and cervix is not fully dilated but edematous and huge caput formation. These are the things that will tell us that the baby mother may rupture the uterus shortly. So you correct the dehydration and acidosis, start antibiotics, try to relieve the obstruction. Most often you may have to go for a earliest delivery depending on the dilatation, position, and the expertise of the obstetrician. Is it a good case for instrumental delivery, or should you do a cesarean section? Is the choice you have. And whenever there is a Bandel's ring, it may be ideal to go for cesarean section rather than instrumental deliveries. Postnatally, you may have to take care of the bladder by catheterizing for 2 to 3 days at least, antibiotics, and correct her anemia. Keep looking for sepsis and continue breastfeeding. Urinary bowel injuries are rare, but it has to be anticipated and it should be corrected. Prevention is good antenatal care, regular assessment, pick up the anomalies as quickly as possible, then malpresentations to be diagnosed in the early labor itself. Don't forget a partogram. This is one thing which really comes to your rescue whenever you have an obstructed labor. A good pelvic assessment, and quickly do an intervention once you diagnose obstruction. So with this, we conclude the problems of the passenger. Now we go to the passage. We have got two entities in passage. One is called contracted pelvis, other is called cephalopelvic disproportion, right? The contracted pelvis incidence is around 5% in India, but in developing, underdeveloped countries, it could be to the tune of 15%. A pelvis in which one or more of its diameter is reduced below the normal by 1 or more centimeters. Please remember, 1 or more diameter. It could be obstetric conjugate, it could be a transverse diameter of the cavity or outlet, etc. Any one of them or more, reduced by 1 centimeter or more than that. But a practical definition is, if any of the diameter is reduced to an extent that normal mechanism of labor is not possible, then it is called contracted pelvis. Usually the problems could be in the pelvis, and sometimes a spine, a crooked spine, a scoliosis, kyphosis will totally alter the architecture of pelvis. So indirectly pelvis is affected. This is the important reason why you should see for the spine examination in obstetrics. Causes in the lower limbs. See, unless you make the patient walk, you will not understand the gait of the patient. There could be a difference in the length of the feet, right? Or there could be a kind of different kinds of gait of the patient, which will make you understand that this patient has got some pelvic issues. So per se pelvic problems, lower limb problems picked up by looking at the gait, and the spine problems picked up by palpating the spine. So causes in the spine, I just told: kyphosis, scoliosis, spondylolisthesis, coccygeal deformities, of course tuberculosis. Lower limbs, dislocation of the head of the femur, atrophy of any one of the limbs, especially poliomyelitis. Of course, now we are fortunate not seeing many cases, but still in some hospitals you may get on and off cases with poliomyelitis coming and delivering, right? How do you diagnose? Look for the gait, look for the stature. Height of the patient is very important. Less than 140 centimeter, you have to think of contracted pelvis. Examine the spine and lower limbs. Look for manifestations of rickets, especially in patients with malnutrition and low socioeconomic status. So when you are examining, look for the weight and height and BMI, hirsutism, stocky build. There is something called dystocia, dystrophica syndrome, and as I told you, nutritional deficiency sign. So how do we diagnose contracted pelvis? Non-engagement of the head in the last few weeks in a primigravida, pendulous abdomen in a primigravida, that is the whole abdomen hanging down below the pubic symphysis is called a pendulous abdomen. Or you diagnose malpresentation and malpositions. You know, Munroe Kerr has very aptly said, if the head is engaged, forget about pelvic contraction and CPD, right? And this is the dystocia, dystrophica syndrome. The lady would be short, stocky build, very obese, subfertile, usually will have polycystic ovaries, and she says, I took treatment for infertility. She has an android type of pelvis. Hirsutism will be there. History of delayed menarche, irregular menstrual cycles, and she is more prone for occipito-posterior position and dystocia in labor. They usually go for cesarean section, right? Pelvimetry, you have got clinical and imaging. Imaging pelvimetry is mostly historical. X-ray we are not doing anymore. Computerized tomography, though it is informative because of the high exposure of radiation, we are not doing. MRI imaging can be done, but it is very costly, not available everywhere, not worth it. So only for research purpose, for pelvimetry, you can use MRI. Otherwise, we rely upon the clinical pelvimetry. So clinical pelvimetry is better done in all the primies, and especially any history of injury to the pelvis or obvious deformities in grand multigravidae, you should do, or whenever you are taking a chance with TOLAC, that is trial of labor after cesarean section. If you are planning for that, you should assess the pelvis. Usually done at term, and if the patient presents in labor, fine, at that point of time also you can do it. Take the consent of the patient. It is an oral consent, not that you have to write and do it. Counsel the patient what you are doing, ask her to empty the bladder, place her in the dorsal position. So you are going to introduce 2 fingers of the gloved right hand, preferably lubricated, and try to feel through the vagina and try to reach the sacral promontory with the tip of your middle finger. So If you cannot reach sacral promontory, be very happy. Don't get disappointed that, oh my God, I didn't feel the sacral promontory. No, feeling the promontory means AP diameter of the inlet is not good. If you don't feel it, it means AP diameter is good. Here you are indirectly measuring the diagonal conjugate, and thus you can deduce obstetric conjugate, right? And in the inlet, you have AP transverse and oblique. The smallest is AP diameter. If the AP diameter is adequate, you can just need not do any of the other things. And this need not be done if the head is engaged, because inlet has allowed the head. Why do you want to worry about the inlet now? So engaged, there is no need to do it. When we come to the cavity, you look for the you go along the sacrum from the sacral promontory up to the coccyx and find whether it is shallow or deep. A deep sacrum like this indicates that it is not an adequate one. A shallow sacral bay is encouraging. And sacrosciatic notch between the ischial spines and the sacrum, you have a notch on which there is the sacrospinous ligament. You try to keep 2 fingers on the sacrosciatic notch. If it admits 2 fingers, that means the sacrosciatic notch is adequate. Then you feel the spines, and if the spines are inverted like this, then it is not a good sign. If they are everted, outside looking, then fine. And at the same time, you also assess the lateral wall of the pelvis, which should be parallel or diverging. A very simple test that can say that cavity of the pelvis is good is that you try to keep 2 fingers of the same hand which you have put in the vagina on both the spines, both the ischial spines. You should not be able to simultaneously touch both the spines at the same time. That is, simultaneous touching should not be possible. If you keep your finger on one of the, that is the right side spine, left side spine should not be approachable. That means the cavity transverse diameter is adequate. Hope I am clear with this. Then you are going to go for the outlet. In the outlet, you have the subpubic angle, wherein it should be obtuse, more than 90 degrees. Then the 4 knuckles you should be able to keep between the 2 ischial tuberosities, which we examine on the perineum, right? Mobility of the coccyx is not a very important finding, but see, now we have assessed diagonal conjugate, that is inlet, side walls, ischial spines, sacrosciatic notch, sacral bay. These 4 things will tell about the cavity, and subpubic angle and the outlet bituberous diameter has told you about outlet. So inlet, cavity, outlet, all these things assessed. So I am happy that the pelvis is adequate. So see, outlet, angle of the pubic arch should be obtuse. This is how it is measured. You can look at the second picture, wherein you are going to, if on the inferior ramus, if you are able to keep the middle finger and the forefinger, it is acute. But if you are able to keep the thumb and the forefinger, it is obtuse. See, that is what is depicted in the picture. You can also measure the head circumference and biparietal diameter by ultrasound, and if it is abnormally high, normally term pregnancy will have 9.4 to 9.5 centimeter. If it is abnormally high, then you can still suspect that this baby may not be able to come. So I told you about CT pelvimetry and MRI pelvimetry. So depending on the contraction, you can call it as inlet contraction, mid pelvic contraction, outlet contraction. But usually if one of the part is contracted, the whole of the pelvis will be contracted. Hope I am clear with this. Now the last part of this session, cephalopelvic disproportion. This tells about the disproportion between the size of the head and the maternal pelvis. If you assess the pelvis, pelvis is fine. If you assess the head, head is fine. But whether this head can come through this pelvis is the one which is assessed by cephalopelvic disproportion, right? A normal sized baby may not be able to come out through a small pelvis. A huge baby may not be able to come out through a small normal sized pelvis also. So we always look at the relation between the baby's head and the pelvic size. So you have to take consent for examination, counsel the patient, empty the bladder, dorsal position. This is always done at term. Don't do it at 30 weeks, 28 weeks and say everything is fine. Baby will grow further. So no CPD at 30 weeks, but at 38 weeks there could be a CPD. So always do it at term when the growth is complete. And it is done only in longitudinal lie with cephalic presentation. Don't do it in breech presentation, transverse lie, etc. So timing is around 38 weeks. And what we do, just remember students, Muller and Munroe Kerr's method, how it is done and what is done. Again, you are going to introduce 2 fingers of the gloved right hand into the vagina. The tip of the finger should be at the level of the ischial spines. In pelvic assessment, you try to touch the sacral promontory. But here, you are just placing on lateral wall, you feel the spine and just keep the fingers there. And you have the thumb here. The thumb is kept on the pubic symphysis to flush with the superior border of the pubic symphysis. This you can comfortably watch in my video in the DigiNerve app. You can see how this is done. So this can be kept on the pubic symphysis anterior surface. And with your left hand, you hold the head of the baby, push it backwards and downwards. When you push it backwards and downwards, that is the axis of the pelvis. When the head goes down, if it goes down and touches the vaginal finger, see, this is the test. What is the observation? Head touches the vaginal finger. It does not touch the thumb. That means there is no disproportion. Head partially enters the pelvis with little difficulty. At the same time, the thumb which is on the pubic symphysis, it just brushes, it just touches your thumb, but it does not come beyond the thumb. So here it is borderline disproportion. When you cannot push the head down at all, cannot enter the pelvis, but instead head comes and sits on your thumb, overlapping on the symphysis pubis, it is called severe disproportion. This is how the disproportion is assessed. So it is minor, borderline or severe disproportion. How do we manage? Minor disproportion or no disproportion, you just do a vaginal delivery. Marked disproportion, go for a cesarean section. But whenever there is a moderate disproportion, you have the option of trial of labor. You try giving a vaginal delivery with all arrangements made for cesarean. If it fails, you can go for a cesarean section, right? Why we try? Because during labor, uterus can really act very well. It can bat for the baby very well and score a century. It can just push the baby down. The head can mold and reduce the diameter of its circumference or the biparietal diameter by a few millimeters and can still enter into the pelvis. When you pushed, it did not go. But when molding occurs, it can start entering. And at the time of delivery, there is relaxation of many of the ligaments which will ease the movement of the baby into the pelvis. All these things will come into picture only when the lady goes into labor. So trial of labor is one very important intervention which can reduce the incidence of cesarean section to a great extent. So with this, we conclude the topic on abnormal labor in brief. I just mentioned about power. I told about passage. I told about passenger. So about passage problems, we are worried about obstructed labor. When we talk about power, we are worried about fetal distress. When we talk about passenger, again, you have the risk of maternal distress and fetal distress. So with this, I'll just conclude my session.